researchers in Africa, and we are an independent network of East African scholars who conduct decision-focused evaluations for social and economic development programs. So right now we do have, our membership is made up of 37 members who are alumni of the East African Social Science Translation Fellowship that is hosted at the University of California, Berkeley. Just to give you an idea of what we do in terms of our activities and programs, our work is anchored on three pillars, that is capacity building, and evidence generation and policy outreach. So in terms of capacity building, we've been building the capacities of different audiences across East Africa in impact evaluation, and we are now implementing a mentorship program that seeks to bring a practical approach to what our trainees have been learning on impact evaluations. In terms of evidence generation, we aim to produce evidence that is demand-driven and that aims to influence policy making across East Africa. So our evidence generation pillar is tied to the policy outreach work that we do, where we aim to engage more closely with the policymakers just to ensure that research findings and every work that is generated by researchers is influencing policy work. So that's it in terms of what we do. We are currently hosted at the university, at the United States International University here in Nairobi, Kenya. And thank you for joining us once again. Just to recap also, our session today involves a presentation from one of our members, who is Dr. Getachew Kassa from Ethiopia, and it entails research findings from a study he's been conducting on systematic reviews and meta-analysis in the health sector, which he will talk about in the next few minutes. So that's it. That's it in terms of who NIERA is. I think I should touch more towards the end on the opportunities that you can actually pursue, or the programs that we have in place for you that you may wish to just look at and pursue as well. So with that, I would like to invite the speaker of the day today, and that is Dr. Getachew Kassa. So take the floor. Thank you.
Thank you so much, Annie, for the introduction of NIERA and for your invitation. So good morning and good afternoon, everyone. Thank you for joining us to this webinar in focusing on dissemination the key findings of systematic review and meta-analysis we conducted. So let me share my slides, and I will start. Great. So Annie, you can see it, yes?
Yes, we can. Yes, we can clearly.
Okay, great. Thank you. So my name is Getachew, and I'm also a member of the Network for Impact Evaluation Researchers in Africa, based in Kenya, Nairobi. And I'm also working as an assistant professor in reproductive health in Debre Marcos University, Ethiopia, and also currently a postdoctoral researcher in maternal and child health researches at the Harvard School of Public Health and the Ethiopian Public Health Institute. So I'm currently based in Ethiopia, where we are working on researches on the areas of maternal and child health. So I'll be presenting you our systematic review and meta-analysis that we conducted on effectiveness of community-based health education intervention programs for the prevention of non-communicable disease in low and middle income countries. We particularly focus on hypertension and type 2 diabetes. So this will be my presentation outline. I will go through describing the problem and the gap of existing studies, the rationale of conducting this study, and review questions we try to address, and the methodology we followed while doing the research, and the results and discussion, and finally the conclusion and implications of the study. So as you know, the nature of the problem. So as you know, non-communicable diseases are a chronic disease that slowly progress over a long period of time. And there are a number of non-communicable diseases. However, the most common ones are cardiovascular disease like the heart attack, stroke, hypertension, respiratory diseases like chronic pulmonary obstructive disease, COPD, the asthma, diabetes mellitus, and others. So these are the common types of non-communicable diseases. And the growing prevalence of non-communicable disease in different cities is one of the major public health problem and major challenge in the sub-Saharan Africa, specifically for the coming few decades. So this is from prediction studies that were conducted previously. So most developing countries are now experiencing a shift of disease from communicable to non-communicable disease. As you know, particularly in the sub-Saharan Africa, the most common cause of morbidity and mortality is communicable disease, but now it's now becoming non-communicable. So both non-communicable and communicable disease are occurring at the same time, and that's what we mean by double burden of disease. And by 2025, more than 75% of people with diabetes below 65 years will reside in developing countries. So the large share of the non-communicable disease will be in developing countries. And there is also high burden of non-communicable disease in the sub-Saharan Africa. And currently, non-communicable disease account for more than half of the overall global burden of disease. And particularly in Africa, diseases from non-communicable disease are expected to exceed deaths from communicable disease by 2030. So, there will be higher rates of mortality and morbidity from non-communicable disease than communicable disease. So we need to integrate prevention mechanisms for this non-communicable disease. And the growing burden of non-communicable disease in the sub-Saharan Africa countries is mainly due to a number of reasons, but mainly due to rapid urbanization and the change in the lifestyle, particularly reduced level of physical activity, change in the dietary habit, particularly low level of fruit and vegetable intake, and the increasing magnitude of substance abuse like smoking and alcohol utilization. These things are considered as the main reasons for the growing burden of non-communicable disease in the sub-Saharan Africa and other low and middle income countries. So this requires an intervention that focuses on reducing these types of behaviors. So if you can reduce these behavioral risk factors, it's possible to avoid up to 80% of cardiovascular disease and diabetes. So we can prevent up to 80% of these problems by reducing these risk factors. And it is also possible to prevent more than a third of cancer-related diseases. So behavioral interventions, health education-related interventions are essential for the reduction of the risk factors and non-communicable disease. And what is known about the core problem, the issue, the burden of non-communicable disease has now become one of the major threats to human health in the 21st century. For example, in 2010, non-communicable disease, including cardiovascular disease, cancer, diabetes, and chronic respiratory diseases account for 65.5% of deaths globally. And more than 2/3 of these diseases occur in the low and middle income countries. So this region is one of the most affected area, and that's why we have selected it in our systematic review. And the recent WHO report in 2021 also showed that about 1.13 billion people worldwide have hypertension. Like 2/3 of hypertension cases are found in low and middle income countries. Again, the most affected region. And the increased risk factors for hypertension are also the main reasons for high level of this disease burden. So if you can reduce the risk factors, it's possible to minimize the problem. Type 2 diabetes also accounts for 90% of diabetes cases globally, and the variation in this case is previously it was common. The type 2 diabetes was common among older population, but it's currently becoming common among younger people. So many children and adolescents are now being diagnosed with type 2 diabetes, mainly due to the different risk factors I mentioned before, like obesity and the lack of physical activity. So these things are now becoming a problem. And there are also health and economic impacts of non-communicable diseases. Serious complications like cardiovascular disease, the morbidity and mortality are common. And there is also crisis of health budget due to direct and indirect costs of healthcare. Like, for example, direct cost of healthcare, indirect costs from family disruption, loss of productivity of the adult population, and premature morbidity and mortality of the adult population, and the resulting low economic income. So all of these things may have its own implication on the health, on the economy status of the country. So in 2013, diabetes alone caused 11% of total health costs worldwide and 5.1 million deaths. And it is also estimated that in the coming 20 years, the global economic impact of non-communicable disease could reach up to $47 trillion if there is no action. So this is a time to take action for that. The rate of out-of-pocket health expenditure in patients with non-communicable disease was also higher in patients with non-communicable disease. So this is also another issue. And specifically when we see research findings, for example, in Ethiopia, more than half or 52% of adult mortality is caused by non-communicable disease, while communicable disease account for 48%. So there is a double burden of disease, and the rate of non-communicable disease is relatively higher. So this is common across different sub-Saharan and low and middle income countries. So that's why this study was conducted. So the burden of non-communicable disease in low and middle income countries is one of the main developmental challenge. Although there are a number of pocket studies conducted on effectiveness of different interventions like health education to prevent non-communicable diseases like hypertension and type 2 diabetes, these findings were inconsistent and inconclusive in terms of their effectiveness in reducing the level of hypertension and type 2 diabetes. And that's why there is a need to summarize these findings and pull the result of effectiveness of community-based health education interventions in reducing hypertension and type 2 diabetes in the low and middle income countries. So that's why we conducted this study, due to inconsistent and inconclusive findings of pocket studies. So the rationale of the study: most low and middle income countries, including the sub-Saharan Africa, are currently experiencing a double burden of disease. And one of the measures, the Sustainable Development Goals or Sustainable Development Goal 3, is to ensure healthy lives and promote well-being for all at all ages by 2030, as you know it. And this Sustainable Development Goal 3 have about 9 targets and 4 sub-targets. And among this is reducing premature mortality from non-communicable disease by 2030. So as a way to achieve this kind of international and global goals and targets, there is a need for intervention programs, like cost-effective intervention programs like health education at community level. And the finding of the study will also be able to guide programs in the prevention and management of hypertension and the type 2 diabetes. And it also helps to identify future studies area. And so we had about 4 review questions. So the review questions are: 1, what are the available community-based health education intervention programs for prevention of hypertension and type 2 diabetes separately, so in low and middle income countries? So this is the review question. And the other review question is related to the effectiveness. How much are these community-based health education interventions effective in preventing or in reducing hypertension and type 2 diabetes in low and middle income countries? So this way the review questions we used to design our search strategy and to identify eligible studies. So we had a general and specific objectives. The general, as I mentioned, is to evaluate the effectiveness of community-based health education intervention programs in the prevention of hypertension and type 2 diabetes among adult population in the low and middle income countries. And specific objectives include to describe the available community-based health education intervention programs for the prevention of hypertension, for the prevention of type 2 diabetes among adults in low and middle income country, and to evaluate their effectiveness in preventing hypertension and type 2 diabetes. So these were the specific objectives. So for the method section, so we used a systematic review and meta-analysis study. So while doing this systematic review and meta-analysis study, we followed the PRISMA guideline, the preferred reporting items for systematic review and meta-analysis. So this is a guideline that should be strictly followed while conducting the systematic review and meta-analysis, starting from the search strategy and up to the analysis and report writing. So we followed that, and the finding of the systematic review meta-analysis are also reported using the PRISMA statement guideline and the MOOS guideline as well. And we were also able to register and publish the protocol of the systematic review and meta-analysis in Prospero, and you can find it using this registration number. So we had a number of criteria for considering studies for this review. Regarding the type of studies, we included only randomized controlled trial studies. The randomization can be at individual or at community level. So both individual and cluster randomized controlled trial studies were included. We excluded quasi-experimental studies, including the pre-post studies. And we also excluded systematic review, scoping review, and study protocol studies. So, and also, of course, other observational studies like cohort, case control, cross-sectional, or qualitative studies as well. And the setting of this study was studies that were conducted in low and middle income countries were included. And the list of these countries was obtained from a recent update report from the World Bank website. So we included all of the low and middle income countries in our study. And the participants of this study were adult population, or the population were adults. And the studies that were conducted that included male and or female population were also included in this study. The type of intervention included were studies that used health promotion or health education intervention delivered at the community level were included. Other types of interventions were excluded because our main emphasis is to look into the effectiveness of community-based health education interventions. And the outcome of this study were hypertension or type 2 diabetes. And for hypertension, we included the systolic blood pressure and the diastolic blood pressure as a possible outcomes. These are continuous outcomes. And for type 2 diabetes, again, we included the fasting blood glucose level. So we included these outcomes to measure the effectiveness. And the time frame and the language, we did not restrict the study, the data collection period of individual studies or the date of data study publication. So we have no restriction on this regard, and we also included studies that were published in English. And the search strategy and source. So the search for published and unpublished studies were included. We have included both published and unpublished to minimize the publication bias. And for the published studies, we searched in different major databases like the PubMed, the Embase, and the CINAHL databases. And for unpublished studies, we searched Google, gray literatures like Google Scholar and Google Hand searches were also used to include unpublished researches. And the final search of articles was on April 2021. Search terms included different types of keywords and the medical subject headings or mesh terms. And we joined this using the different Boolean operators. And we used a PICO criteria for the search for the preparation of the logic grid, which will help us which helped us to search for different eligible articles in major databases. So the population was, as I said, adult population. The intervention were community-based health education promotion intervention. The comparison was the usual or the standard care other than the actual intervention. And the outcomes were for hypertension, the systolic blood pressure and diastolic. And for type 2 diabetes, we have fasting blood glucose level. And we also screened the reference of the final included studies to retrieve possible additional studies that could be included. And we exported the findings or the search results to Induno software so that we can easily manage the searching process. So we use Induno version 20 software. And the data extraction and the risk of bias assessment. For the data extraction, we modified the tool developed by the Joanna Briggs Institute. So there is a data extraction checklist for randomized control trials. So we used that, and we included information on author name, publication year, data collection period, study design, information related to the type of intervention program, and information related to the outcomes and other variables essential for our study. And we also assessed the risk of bias of each of included studies. And there is a recent version 2 of the risk of bias assessment. This is developed by the Cochrane risk of bias tool. By the Cochrane. So we use that for randomized trials. And the tool contains, there are about 5 major domains in the risk of bias assessment tool. This include like bias from randomization process, possible bias from deviation from intended intervention, bias from missing outcome data, measurement of the outcome, and bias from selection of the reported results. So we evaluated each of the included studies using these specific 5 domains, and we finally gave a score for each of this as low risk of bias, some concern, or high risk of bias for each of the included studies. And this was done by 2 reviewers separately. And the heterogeneity and publication bias. So for the heterogeneity, we assessed the heterogeneity. This is the variation of studies included in our review. How much is the variation? Are the studies homogeneous or heterogeneous in terms of different characteristics? So we use the I-squared test statistics, and p-value less than 0.05 was used to determine whether there is a significant heterogeneity or not. And when there is a significant heterogeneity, we use the meta-regression analysis to identify the source of heterogeneity. And we also use different mechanisms to modify that, like subgroup analysis, the sensitivity analysis as well. And publication bias was also assessed using the Eggers regression symmetry test and visual inspection of the funnel plot. And we analyzed a separate publication bias assessment for the different outcomes of the study, and significance was declared when the p-value was less than 0.05. So in the presence of publication bias, we use the tree-band field analysis to accommodate that. And finally, the data processing and analysis, we conducted the meta-analysis since we had continuous outcomes in a number of studies. And the meta-analysis was conducted using the random effect model. And this random effect model was used because it minimizes the heterogeneity of different included studies than the fixed effect model. So we prefer to use a random effect model due to its benefit in minimizing heterogeneity. And subgroup analysis was also conducted by different study level characteristics. And we used forest plots to present the mean difference, the standardized mean difference, since we had we have the continuous outcomes with a 95 confidence interval, and to see the effect of the intervention, which is community-based health education intervention, on the outcomes of the study separately. The meta-analysis was also conducted using the Stata software. Great. So coming to the result and the discussion. So first, to show you the overall process of the searching. So we followed different steps to select a total of 25 studies. So at the beginning, there were about more than 40,000 records from both published and unpublished sources, including the major databases. And from that, we tried to remove a number of duplicates, as you can see from here. And then we also reviewed the articles, the left articles, using their title and the abstracts. And we also excluded those that are not eligible for our study. And finally, we included about 250 for full texts for eligibility assessment. So we assessed this 254 articles using our prior eligibility criteria I was mentioning before, like the type of study design should be randomized control trial, the population should be adult population, and the outcomes should be hypertension and type 2, specifically systolic blood pressure and diastolic, and fasting blood glucose for type 2 diabetes. And so using all that prior eligibility criteria, we excluded 229 full texts, and finally we included a total of 25 articles for our quantitative synthesis or for our meta-analysis. So this is the overall process of the searching process. So all of these steps were done by two independent reviewers, and then we had 25 articles. So the finding of this study is the result of 25 studies. So characteristic of these 25 studies, from the included studies, 22 studies were used in the meta-analysis because their outcomes were quantitative, and 3 studies were used only in the narrative sentences, since there was no quantitative outcome in here. Studies were conducted from 2006 to 2020, and about 18 of the studies were randomized at community level or were cluster randomized controlled trials, and the rest were individual randomized trials. And when we categorize, when we see by country, there were 6 studies that were conducted in China, 4 studies were conducted in India, and 3 studies were conducted from Iran. The other 12 studies were conducted from 11 other countries. So we can see a large number of countries were represented. And when you see by region, 8 studies were conducted in East Asia and Pacific, 8 from South Asia, 3 from Middle East and North Africa, and 3 from the Sub-Saharan African region. So we have also different regions included. By income level, more than half or 56% of the studies were conducted in upper middle income countries, and 10 studies were in lower middle income countries. And the sample size, so the sample size, since there are different sample sizes at baseline, at follow-up periods in experimental studies, we counted the baseline sample size for both groups. So for the intervention group at baseline was 10,706, and for the control group was 10,908. So this sample size was the baseline sample size. So a large number of population were included in this systematic review. And when we describe the intervention program and the outcomes, the intervention programs, all of the studies used a community-based health education program, and the health education was given at individual and group level. So individual and group-based health education interventions were given at community level, and those individuals who provided the health education were peer educators, trained peer educators, trained community health workers, community health extension workers, as in case of in Ethiopia. And we also have health workers like nurses, pharmacists, physicians, volunteers, and trained users were also involved in the delivery of the health education. And for the outcome from the 22 studies included, 30 studies reported hypertension as a major outcome of their study, and 8 studies reported both hypertension and type 2 diabetes. And we identified only 1 study that reported the type 2 diabetes only. So we included all of these studies in our meta-analysis. And when you see the major finding on the pooled effect of the intervention on the systolic blood pressure, as you can see from this figure, we included a total of 12 studies for the assessment of effect of health education, community-based health education on the systolic blood pressure. And as you can see, the findings in the forest plot is presented by different follow-up periods. So those who had 2 months follow-up, those who had 3 months, 6 months, 12 months, up to 24 months follow-up. So separate meta-analysis, pooled meta-analysis were conducted for each of the follow-up periods. So 13 studies, that is, although the total number of studies were 12, there were 20 outcomes when you count the separate follow-up period. So a single study may have more than follow-up period and more than 1 or 2 outcomes. So due to that reason, we had a larger number of outcomes than the actual number of studies included. So certain studies were significant in the reduction of mean change of systolic blood pressure from baseline to endline after the intervention program. So the estimated mean change was 0.24 millimeter mercury lower for the treatment compared to the control group. So those individuals who had a community-based health education intervention had 0.24 millimeter mercury lower systolic blood pressure compared to the control group. So there was effectiveness in of community-based health education intervention in the reduction of systolic blood pressure at the end of the follow-up. This is the overall, but there are variations in the specific follow-up periods, as you can see from the figure. And when we conduct a sort of subgroup analysis by the income level of countries for the systolic blood pressure, so we identified that the community-based health education interventions were effective in reducing systolic blood pressure across the 3 income levels. So studies, in fact, there was only one study conducted in low-income countries. So that study was effective in reducing the systolic blood pressure, the mean change, and for lower middle and the upper middle, for all of these income levels, there was effective reduction in the level of systolic blood pressure. So community-based health education was actually effective. And this finding was actually similar to other meta-analysis study conducted in China, which showed an effective reduction of health education programs on the systolic blood pressure of the study participants. And this is also another subgroup analysis of the effectiveness of community-based education program in reducing the systolic blood pressure of respondents. And as you can see, we conducted a separate meta-analysis for different study characteristics, like for example, by the type of study design, RCT individual-based randomized control trial and cluster randomized control trial. In both cases, there was significant reduction in the mean change of the systolic blood pressure. And by region, in all of the regions like South Asia, East Asia, Sub-Saharan Africa, and 2 regions, Latin America, Caribbean, and East Asia and Pacific, and others, in all of the regions, there was also significant reduction among the intervention population. And by publication year, starting from 2010 to 2020, there was also significant reduction, and by risk of bias of the studies, there was also. So in all of the different characteristics, including the subgroup, there was significant reduction of systolic blood pressure. The effect of the intervention on the diastolic blood pressure, when you see this, so this is also another figure showing the effectiveness of the community-based health education on the diastolic blood pressure of study participants. And so we included 10 studies here, and similar to the systolic blood pressure, we categorized the studies by different study follow-up period, and we had about 21 follow-up periods and 21 outcomes reported. And there was variation in the significance by different follow-up periods. So for example, in the first 2 months, there was statistically significant reduction in the level of diastolic blood pressure. At 3 months, there was no significant reduction, although the point estimate shows lower. At 6 months, there was significant reduction. At 12 months, at 18 months, and at 24 months. So with the exception of 3 months follow-up period, all other follow-up periods had reduction, shown a reduction in the mean change of the diastolic blood pressure among those who received community-based health education compared to the standard care. And such kind of variation, in fact, by follow-up period could be due to the number of studies included in each of the categories. And the overall effect showed an estimated mean change of 0.18 millimeter mercury lower diastolic blood pressure for the treatment group, or for those who had community-based health education program compared to the control group. So there was also effective reduction in the level of diastolic blood pressure. This is also another key finding. And when we see the finding by the income level of countries, so we can see from this figure, there was a significant reduction in the lower middle and upper middle countries. However, there was no significant reduction in low income countries. This could be, in fact, due to variation in the number of studies. As you can see, there was only one study included in the low income category. However, there were a number of other outcomes, study outcomes included in the other categories. So that could be, in fact, one possible reason for the variation, and the resulting the study period, the sample size, and the like. That could be the main reason for this. And the other is the fasting blood glucose level. For the type 2 diabetes, we had this outcome in our study. So we categorized the outcomes. So we included about 9 outcomes from different studies that were reported. And from that, as you can see, the final estimate, the overall estimate at the bottom, the bottom of the forest plot shows that the estimated mean change of fasting blood glucose level was 0.14 milligram per deciliter, lower for the treatment group compared to the control group. So there was effective reduction of fasting blood glucose level in the groups who had community-based health education compared to the standard one. So this was also one key finding of the study. And this was also supported by other previous meta-analysis studies conducted on the type 2 diabetes. And when we see by income level, this was significant for studies that were included in the upper middle income category, but not in the lower middle income category. Again, the variation in the number of studies included could be the reason for this. And we also conducted meta-regression to identify the source of heterogeneity. As you have seen from the forest plots, the different outcomes for diastolic, the systolic, and the fasting blood glucose, there was significant heterogeneity. And for that, we conducted meta-regression to identify the source of heterogeneity. And we identified that after including a number of variables like publication year, sample size, and the like, only variables like sample size and income status of countries were significant variables, and they were the main source of heterogeneity for the systolic blood pressure outcome. But for diastolic blood pressure and fasting blood glucose outcomes, we did not identify significant variables that could be mentioned as a source for the heterogeneity, and the heterogeneity could actually be due to other reasons we did not include in our study. So the variation in the sample size and the variation in the income status were the main reasons for heterogeneity for the studies included in the systolic blood pressure outcome. And we also assess the risk of bias of studies. And this is a figure showing the risk of bias of included studies. So as I have said before, we included all of these studies, 21 studies in our study, 22 studies in the meta-analysis, and we assessed their risk of bias using the ROB2, the version 2 assessment tool developed by Cochrane. And as you can see, the green color is a low risk. If the study is assigned as a low risk, it will be green. The yellow is for some concern, and the red one is for high risk studies. So there are about 5 domains. So each individual studies will be assessed using these 5 domains, and there will be an overall score for that. So as you can see, there were 11 studies that were grouped as overall risk of bias assessment score of high risk of bias, and 10 studies were ranked as some concern, and 4 studies were categorized as low risk of bias. This is particularly for randomized controlled trials. And however, it should be noted that this classification is mainly based on the judgment of authors of this study and not for the purpose of for other purposes. So this is mainly for the purpose of this study and based on the judgment of the authors. So this was the finding of the risk of bias assessment. And so as a conclusion, community-based health education programs were effective in reducing the mean change of systolic blood pressure, diastolic blood pressure, and the fasting blood glucose level in low and middle income countries. And the integration of community-based health education program for non-communicable disease in low and middle income country can be used as an essential component of chronic disease prevention and management. It can be integrated because our study identified that it is actually effective in reducing the systolic, the diastolic blood pressure, and the fasting blood glucose level. However, it should be noted that the risk factors for hypertension, for type 2 diabetes, and other types of non-communicable diseases are diverse because there are a number of factors like genetic factors, environment, and other social factors. So future intervention programs and future researchers should consider these issues. And prevention and control of non-communicable disease also should consider the diverse nature of the risk factors for non-communicable disease. And possible implications of this study: one thing, the use of community-based education program in resource-limited settings for prevention of hypertension and type 2 diabetes mellitus can be used. And the other issue, given the increasing number of chronic disease conditions in low middle income countries, community-based education program may require a large community health workers, and this is in fact one possible challenge that countries in low and middle income country may face while considering this type of intervention. And future studies should also consider on the effectiveness of community-based education program for prevention and management of other non-communicable diseases other than hypertension and type 2 diabetes. And in fact, although we have selected systolic blood pressure, diastolic blood pressure, and fasting blood glucose, there are other possible outcomes that could be included for the hypertension and for type 2 diabetes, like for example, the glycerated hemoglobin, HbA1c, the body mass index, the cholesterol level, the high density lipoprotein, and the low density lipoprotein can also be possible indicators. So by using these different outcomes, future systematic review and meta-analysis can also be conducted. There were short follow-up periods for most of the studies. As you have seen, the longest follow-up period was 24 months. So it was very difficult for us to synthesize the long-term impact of the intervention program on the different outcomes of the study. So future individual studies, randomized control trials, should consider assessing the effectiveness of the community-based education intervention for a longer period beyond 24 months. And these are some of the selected references we used. And finally, we would like to acknowledge NERA for funding this study and for researchers of the primary studies included in this systematic review and meta-analysis. Thank you very much. So this is my presentation. Annie, back to you.
Thank you very much, Dr. Getachew Kassa. I think we can now move to the Q&A section. So for the audiences, please feel free to post your questions on the Q&A section. I already see that we have a question from Doris. Doris, please feel free to speak. I think you can do that now. Doris, can you hear me? In the meantime, I can read out a question from Tebike, if I got the name correctly. So Tebike says, would you share with us whether your systematic review tried to address other emerging NCDs, such as mental health problems, e.g. depression, cancer, and asthma? I see your study scope is hypertension and DM. Will you consider those studies, those diseases in your future studies? That's a question from Tebike.
Yeah.
Right.
Thank you, Toby. That is an interesting future research area. As you have tried to mention, our study was particularly on hypertension and type 2 diabetes. We consider this disease as our outcome because of the morbidity and mortality these diseases are causing currently, and that these are the common types of non-communicable disease. But I think future studies on different outcomes like cancer, chronic obstructive pulmonary disease, other mental health conditions are also possible areas, and that's a good recommendation as well. But ours mainly focus on hypertension and type 2 diabetes. Yeah. Thank you again.
Great. Please continue to post your questions in the Q&A section, and we'll also have, and feel free to raise your hand as we proceed. So I see a comment here. It's more of a comment and a question at the same time from Faisal. So he says, I think there is no standardized intervention dose currently, the duration and component doses of community-based health education for each study are different. Thus, how do you handle it? Especially what will be your recommendation at the end to mitigate the two high burden diseases?
Yeah.
Dr. Kassa?
Yeah, that's good. Thank you, Fasil, for the important issue. Yes, I think one of the main challenge while conducting systematic meta-analysis studies is the heterogeneity that may exist in the included studies. So some studies may assess the outcome differently, while others assess in a different way. And even the way the intervention has been delivered. Some deliver the intervention by community health workers, others deliver the intervention by trained healthcare workers like nurses, physicians, while others also consider using peer educators. So this kind of variations occur in systematic review and meta-analysis studies. So one way to solve that issue is doing a sort of subgroup analysis. So we conducted a subgroup analysis by the type of health educators, the type of intervention provided, and even the type of duration of intervention. Some studies may provide just a one-time health education, while others provide 2-3 times for menses. So this kind of subgroup analysis may be able to help you minimize the impact of the heterogeneity of the studies. So all in all, what we identified in our study was we conducted a separate subgroup analysis by different follow-up periods. So for studies that had a 3 months follow-up, for studies that had a 6 months follow-up, 12 months, for 24 months follow-up, we conducted a separate meta-analysis, and we actually identified that there was a significant reduction of mean change of systolic blood pressure, diastolic blood pressure, and as well as fasting blood glucose level. So interventions are actually effective irrespective of the follow-up period, with the exception of 3 months follow-up for the fasting blood glucose, of course. So there was effective. That is the conclusion we had. So thank you again for that point.
Great. Thank you for that. Please continue to ask us questions if you have any on the Q&A section. I would like to invite Doris, EASSI. I see your hand has been raised. Great. Maybe I can move on to Doris, can you hear me? All right. Please keep on asking any questions. I don't know if you have further comments, Dr. Kassa, as we look into other questions.
Yeah. In fact, we included only randomized controlled trials. So I think the use of randomized controlled trials increases the generalizability of the findings because of the inherent characteristic of the randomized controlled trial studies. We excluded quasi-experimental studies because of the lack of randomization in that kind of study. So I think findings of the current study are good because of the eligibility criteria we included in our study. But again, as I said before, particularly for the fasting blood glucose level, for type 2 diabetes, fasting blood glucose is not the only measurement, or is not the only indicator. There are a number of other indicators I mentioned before, like the glycemic hemoglobin, which is also effective in identifying the level of fasting blood glucose, the level of insulin resistance, and the like. So I think since there are researchers in this webinar, they can conduct future studies that included other types of outcomes, like the glycerated hemoglobin, the cholesterol, the high density lipoprotein, the low density lipoprotein in case of hypertension and type 2 diabetes. So these are also possible future research area, but the use of randomized control trials is a plus, an advantage for this systematic review again. Yeah.
Great, thank you. As the questions stream in, maybe I can mention that this is one of the many webinars that we are organizing to disseminate systematic reviews and meta-analysis conducted by our members. And this cuts across different sectors. So we do have another webinar coming up on the 22nd of October from 11 a.m. to 12 noon Nairobi time, and this will be a presentation from one of our members also by the name Dr. Mbate, and he'll be presenting on his key findings as well in the governance and a governance sector for sure. I don't know if you still have more questions.
Yeah, we have one question from Henok. Does this study has a protocol, since you used the JBI as a guideline? Yes, we actually have a protocol. We prepared a protocol for this systematic review and meta-analysis, and we were able to submit that protocol to Prospero. And I also mentioned the Prospero registration number in the meta section, so it's available. Thank you for that again. And thank you for others for the comments as well.
Great. As we keep on asking your questions, I think it's important for me to mention also. So besides our evidence generation activities, NERA, which is one of NERA's mandates, we are still continuing with our capacity building activities. We do have a program that is in partnership with the Utrecht University from Netherlands, where we are looking at training students, master students, researchers across East Africa. And these are in selected institutions, academic and research institutions. So I'll be sharing more details. The impact evaluation trainings that we have availed through this specific project will be starting sometime towards the end of this month up until next year. And you'd have to be, one of the eligibility criteria is that you have to be based in the selected academic and research institution. And just to highlight, if I can mention the selected institutions as well, so that you can keep an eye on whether you are based in that institution and just register when that time comes. So the institutions that we are partnering with are Kenyatta University here in Kenya, Jomo Kenyatta University as well here in Kenya, and we have Deborah Marcos University from Ethiopia, and a research institution by the name Policy Study Institute, also based in Ethiopia. So in Uganda we have Makerere University, and in Rwanda we have the University of Rwanda, and in Tanzania we have Kilimanjaro Technical University. So that's just to mention that through this project that I've just mentioned, if you're based in the institutions that I have just mentioned, you have an opportunity to get trained free of charge. This is fully funded by NERA in partnership with the Utrecht University. So that's it for the capacity building activities. I also want to take this opportunity to invite you to follow us on our social media platforms, just to keep an eye, or rather get updated on the programs that we have in place and any other opportunities that is available for you based on the sector or industry that you're in. Just keep an eye on our website, or Twitter and LinkedIn. I should be sharing the platforms in the chat section. So do follow us as well. I see we have a question here from Fasil again. From Fasil for sure. Do you think that the risk of bias for small study and large study, e.g. high risk of bias for small sample versus to high risk of bias for large SS will have equal contribution in the overall risk of bias assessment? I hope that, should I come again?
Yeah, I got it. I'm also reading the question. Great. Yes, yeah. The risk of bias assessment is particularly for randomized controlled trial studies, and so there are 5 domains, as I mentioned. Risk of bias that may be introduced while doing the randomization, while doing the allocations, the outcome reporting, the follow-up, and the like. So there are about 5 domains. So each of these domains are assessed. I mean, each of the articles included in our review are assessed for each of the domains. So I think the concern here is that small study and large study, high risk of bias for small sample versus high risk of bias for large sample size. Okay, in the overall risk of bias assessment, I think, in fact, I used an Excel software to pull the overall risk of bias assessment, but I don't think the sample size will be a matter in terms of assessing the overall risk of bias assessment. Specifically, while doing the meta-analysis, we have an option in the forest plot, which is called the weight. So the weight for the final meta-analysis is proportional to the sample size of each included studies. So the higher the sample size, the larger the weight it will be given while estimating the overall pooled estimate. But for the risk of bias assessment, each of the article is assessed based on 5 separate domains. And I don't think the sample size will have its own contribution, or there will be equal contribution of each included studies irrespective of their sample size. So the overall risk of bias assessment will be irrespective of their sample size. It will be particularly based on the 5 domains included. So maybe as part of the domain, there may be sample size in that, but that sample size is for each of the studies. So that is the point. If I'm clear, if not, you can also include the concerns you have. Thank you, Faisal, again. Yeah.
All right. I'm just sharing events that are coming up just to keep you on the loop in terms of the programs that you have lined up for you, and we'll have more in the month of November. Just see if we have another question here.
Yes, it's also good to mention that since most of the participants now are from the health sector, from the health team, we also have other health team, systematic review and meta-analysis on HIV, I think, and we also have another on tuberculosis and HIV and the like. So there will be an upcoming webinar on this areas as well.
Fantastic. I hope you're not closing anyone out. If you have any questions, please feel free to raise your hand or post in the Q&A section as well. So in the meantime, allow me to share the link to the project that I've just mentioned. It's called Contextualizing Impact Evaluation Pedagogy in Africa. It's our joint initiative with the Utrecht University, and to aim at building the capacities of researchers, students, and policymakers in the said institution. So, a minute. Great. I think, if I'm not wrong, we do not have any further questions. And if you can allow us to conclude at this point.
Yeah.
So great. So thank you very much all. Thank you, Dr. Getachew. Thank you, participants, for joining us today. We will share the presentation for your reference after this, and the recordings as well, just so you can reference at your own time. Oh, we do have, I don't know, we have another question. I think it's more of a question. Yeah, we have a question from Tewikyo. says, would you summarize those benefiting interventions in the form of CF?
CF. Can you explain CF? Sorry, Tabuko. Maybe you can write it. Maybe if okay, that's good. I think that's one way to summarize intervention is included, although I don't have it in my presentation slides, but the overall characteristics of the interventions included in our review, or the interventions used by the individual studies is, as I mentioned, all of these studies were community-based health education interventions, and there are some studies that used some sort of models, behavioral models, like, for example, the health belief models were used by few studies, and there were also other models that were used, and some studies used health education in the form of video, in the form of just lecturing, and in the form of discussions, group discussions as well. So there were a number of intervention programs utilized, but what makes all of these interventions common was these were implemented at community level, and that there were trained individuals who delivered the interventions, like the community health workers and the like. So, and that is the point I'll be saying here. But I think it's also good to describe the overall character. So, in fact, we have a table describing the benefit, the interventions, the characteristics of interventions in general. The objective is the use of models, the individual who provided the intervention, the time duration that were used while providing the intervention, and the like. So there is a detailed table, and that can also be prepared in a form of conceptual framework, of course. Yeah. So thank you for that point.
So thank you very much. Thank you very much for joining us today. That brings us to the end of this session. And as I mentioned, please join us in the upcoming webinars that will focus on different sectors as well, that will entail presentation from our members on the key findings of the systematic studies that they've conducted across different sectors. So keep an eye on our website on the upcoming events, as well as our Twitter handle and our LinkedIn handle as well. So thank you very much.
Thank you.
Please have a good evening ahead.
Yeah, thank you everyone again for your time. It was a very fruitful discussion.
Thank you.
Thank you, Anna, as well.
Thank you too.